Good morning, everybody. Welcome to this EFIC webinar on pain in special populations and comorbidities. I'm Mary O'Keefe. I'm the Research Project Officer here at EFIC, and I'm delighted to be joined by three of our speakers from the EFIC Academy. So we're joined by Annalene Malfay, Owen Judy, and Stephanie Poulton. And if you haven't attended one of these webinars before, the style is question and answer sessions. So we're hoping that you can use the Q&A function or the chat to ask any question that you have of these speakers, and we're happy to answer together or have a good discussion. So we'll just allow some participants trickle in for maybe the next minute or so, and then our speakers will introduce themselves and we'll get straight into the questions. Okay, we might as well get started and people can trickle in as we go. So Annalene, would you like to introduce yourself first?
Yes, thank you, Mary. So hi, everyone. I'm Annalene Malfay. I'm a physiotherapist, and I'm currently appointed as an assistant professor and a postdoctoral researcher at the University of Brussels. And in my research, I'm focusing on chronic pain rehabilitation, with a special interest on overweight, obesity, and nutrition and their relation to pain.
Super. Thanks, Annalene. And Owen?
Yeah, Owen Judy, Department of Nursing Midfield, University of Limerick. I'm a senior lecturer, intellectual disability nursing background, and focused on intellectual disability and pain.
Super. And finally, Stephanie?
Hi everyone, so I'm Stephanie Poulton. I am a physiotherapist also by background, and I am currently working as the head of long COVID service within East London. But my previous work has been very much within persistent pain and a little bit in MECFS.
Great. So I can open up with the questions, but just a reminder to participants, if you have any questions about nutrition, obesity, pain, intellectual disability, and pain among people and long COVID among your patients, please ask our speakers today because they're experts in these topics. So I'd like to kick off with one question, and it's for you, Owen. So when I was watching your lecture on the Academy, I was really struck by the misconceptions you say that health professionals have about pain among people with intellectual disability. So maybe they don't feel pain, or their pain thresholds are different and so on. Can you speak a bit more to this, as in how common is this problem?
Okay, yes, I suppose if we take a step back, and if you even think of someone with intellectual disability, would you recognize if they're in pain? If you brought someone if you've cared for someone or been in interaction with someone with a disability, would you recognize they were in pain? And I suppose how much of behaviors are when you meet a person with an intellectual disability, kind of the behaviors about might be seen as acting up or behaving poorly or behaviors of concern rather than suspicion of pain. And I suppose that all feeds into the misconception around pain and people with intellectual disability, because a lot of their non-verbal communication is seen as indicative of them having an intellectual disability, of being behavioral problems per se, rather than an underlying issue or a health issue. So, and like the evidence would say, even post-surgery, they receive less pain relief. So it is still common. So we might like to believe that we're person-centered and that we treat everyone fairly and have equity for people. But the reality is that our preconceived ideas, and if a person can't verbalize their pain, and a lot of the time people with intellectual disability will display atypical behaviors. So it could be giddiness or laughing that is their expression of pain, rather than calling someone over and pointing to an area and crouching forward. So there's a number of factors. There's the preconceived ideas, there's this behavioral displays by a person with intellectual disability, and then it's how we match them clinically in practice. And as I always say, if in doubt, you can give paracetamol. If behaviors alleviate after 20-30 minutes, you know that it's reacting to the paracetamol. So now you have to go back and do a further clinical assessment to try identify the source of the pain.
And yeah, that's interesting. So what about if somebody is in the community, maybe their family doesn't know pain is the problem, but the person could have some serious underlying condition that needs care? Do the misconceptions look different in the healthcare environment versus, let's say, the community among families and carers?
Yeah, there is, I suppose, it is prevalent in the community and in families as well, but a lot of the time it's in families because they've been withered and told that it's behavioral, so
yeah.
Every parent knows their child and knows when there's something different or something wrong. It's an innate intuitive parenting skill. And I suppose if that's not listened to over time, they become withered and exhausted of that and maybe come to believe. But I suppose there's health trajectories for people, and they're there for people with intellectual disability. We know maybe someone with cerebral palsy who has gastric reflux, sitting in a wheelchair, is maybe more prone to developing ulcers and esophageal cancers later on in life. So there's connections. We're not connecting the dots. We don't maybe visualize what might be the health trajectory, what is their previous health history, what is their underlying condition, and do the connecting of the dots a lot. We're looking at what's immediate in front of us, and that doesn't lead to good healthcare in the case of anyone, and not just a person with a disability. That's not effective healthcare. It manages the situation, and if it's an immediate admission or A&E visit or emergency department admission, it gets you through that admission, but it doesn't solve the problem.
Yeah, we have a question here from Lorianne. So thanks, Lorianne, for your question. Are there resources to help families and caretakers to work on communicating between the patient with disabilities and the doctors?
Yeah, so there is, there's a lot of resources, and I suppose it will depend on what, there is, I suppose, national resources in different countries, and they approach it differently. So internationally, you have maybe developmental disability associations that provide support for professionals and carers. Would have information around caring and communication. healthcare organizations as well. We'd have training programs in Ireland, for example, on HSE land in relation to pain and communication and working with people with disabilities. And a lot of the family organizations, like you have MenCap, they have information about communicate with people with learning disability. The National Health Service, augmentative and alternative communication videos. Other countries might have health passports or health adjustment systems in place. There is national healthcare communication programs in a lot of countries as well. There's customer communication toolkits for public services that have been based on a universal design approach that would be very useful for dealing with anyone with communication problems. And there's many countries national guidelines on accessing health and social care, and they often have guide documents attached to that with the provision for people with communication needs and accessible services and accessible read information. So there's many resources. I suppose it's knowing your landscape. I know on the National Health Service, they have a lovely one on gastric esophageal reflux information for patients, and it's done as a user-friendly one, and that could be used with families as well. So, there's one on pain relief and music, as well out there. So there is good information. It is how we gather that, and I always say that's the work that we as educators need to be getting our students to collate and bring back, and because they are the future practitioners, but also they infiltrate the practice with that knowledge or those resources or those tools or that information. So that's important.
One thing that got me thinking about the misconceptions, and that's such a big problem if we're to assess and then go on to manage pain, is has there been any campaigns done? So when I think of misconceptions, my own area, back pain, there might be campaigns done by researchers and clinicians and tested to see, does this change misconceptions over time? And it's similar, they're trying to do the same with knee osteoarthritis because of a lot of the misconceptions about physical activity being dangerous. Has that ever been done for pain in intellectual disability? A kind of a more, I suppose, an awareness campaign, which is different to resources. Do you know?
I haven't any knowledge of it, and it, funding for projects is difficult. Disability seems to score less priority down the line, so it is difficult. And I suppose maybe it is about, and this is where I would say, the likes of RCTs and any research to having a disability arm, and that is disability as inclusiveness, which there's physical, sensory and intellectual, it's not just intellectual. And we need to do that, there's the absence and representation of people with disabilities across most studies and most RCTs and most campaigns. And where there will be targeted groups, that's great, but I think we could be more inclusive the way we target groups as well. There is, I suppose, people will be aware maybe of the incident and situation in the UK and Ollie McGarr, and the training program that is to come into place. Can see difficulties with rolling it out to every National Health Service worker in relation to awareness about disability. But that has come from I suppose inequalities, poor access, poor attitudes, all those things within a healthcare system. And if it's not in your country or in my country, we're probably just a phone call away from it, or a scenario away from it. We might think we're doing very well until something comes to light, and that's what would be, I suppose, the worry. And maybe when we see, if we want to say it's not the best word, but poor practice and how it's dealt with, and how it comes to light and how it's dealt with, just because it's not in light in our area or our country doesn't mean that we shouldn't learn from poor practice elsewhere, and the actions that are and recommendations that are made bring into place. And I suppose that's that would be the campaign, but one sole person can't do that. But I think there would be opportunities around awarenesses campaign, joining 2 or 3 awarenesses campaigns that would have similar aspects.
Yeah, definitely. And, randomized controlled trials mightn't be the best way to test the effectiveness of that campaign. But yeah, definitely that would be something worth considering. Thanks, Owen. I might pop on to Stephanie. So Stephanie, thanks for your presentation on the Academy. Can you give us any updates since doing that presentation on the prevalence of long COVID among maybe your patients with pain?
Sure. I mean, I suppose the sort of the patient population I'm seeing at the moment are people who are referred predominantly with the symptoms of long COVID. So it's not so much, pain patients that I'm seeing, but it's people coming in with this as their, suspected diagnosis. But pain appears to be within the top 4 symptoms that people are reporting. And I suppose that what we're kind of experiencing is a few different presentations where there might be people who have had a previous history of pain, so they have had persistent pain in the past, and then perhaps they were managing it quite well, they sort of had some strategies, but having a COVID infection has really kind of tipped it over the edge to a point that they're really struggling to manage the pain in amongst then a sort of cluster of other symptoms they're experiencing. So that's kind of one picture that we see. Another one is that people are coming with just, new pain. So new pain that they haven't experienced before. And in lots and lots of different places. Could be kind of joint and muscle pain. And also just something that doesn't seem to kind of correlate with presentations that we usually see. So, for example, just pain affecting, the front of the thighs, for example. And so something that just sort of doesn't make sense to us in our usual kind of musculoskeletal framework. And then also, I suppose the third sort of aspect of pain that we're seeing is kind of dysesthesias. So just unpleasant sensations that people are experiencing kind of body wide, or they kind of come and go with kind of a bit of a sort of, I suppose, like if you think about a central sensitization type pain mechanism that's just unpredictable. It's just sort of a bizarre descriptor. It doesn't have a sort of a locator that's associated with dermatomes or myotomes or anything. It's sort of just something that's quite random that then people just struggle to kind of make sense of and manage. So I guess that's what we're seeing in terms of the pain presentations. And with the advent of vaccinations, we have seen I think a reduction in people coming through with a diagnosis of long COVID. So it's about 1 in 25, we think, at the moment, although it's harder to kind of track who goes on to get long COVID, because we're not testing in our country anymore for COVID infections. So cases, total number of cases is sort of difficult to predict. But because we work really closely as well with our persistent pain service, that's the service that I came from and kind of switched over to long COVID. We do know that they're experiencing, their existing patients having exacerbations of their pain since having a COVID infection as well.
And with long COVID, it must be so stressful from a differential diagnosis perspective for you and your colleagues. What does that look like? As in, when someone comes to you, I suppose, number one, how do you make the diagnosis of long COVID? And do you find yourself sending people off for lots of investigations, bloods, imaging? Or I guess I'm just interested in what does it look like on the ground when a person comes in?
So in order to kind of, because long COVID is essentially a diagnosis of exclusion. So it's just making sure that we're not missing something else presenting with these really common symptoms that are common to many many conditions and potentially quite serious conditions. So people can be experiencing palpitations, chest pain, and you know, as therapists, particularly for me as an MSK therapist, I don't have a strong background in kind of cardiorespiratory. So a few things that we put in place and also kind of fits with our national recommendations. So NICE put together some really, really helpful guidance that we follow, and the access to these post-COVID services are by GP referral. So that's the first kind of point of screening. So the GP is to assess somebody as they would anybody presenting in primary care, to kind of rule out any of the more serious potential conditions. And then what we ask for before people are referred to us is sort of a real kind of battery of tests. So a set of bloods, and then other investigations depending on their symptoms. So it might be a chest X-ray, an ECG, a 24-hour Holter, something like that, to just rule out that there's not something more serious underlying, in which case someone is better served in one of the existing pathways. So if all of those investigations are normal, then we would accept the referral into our service. And that's not to say those basic those investigations are sufficient to be ruling everything out. So then how we have set ourselves up, we are very much a, you know, there's a really strong kind of rehab element to the service that we provide, but we're really closely linked into respiratory consultants within secondary care. We've also got a GP within the service. So if we have questions about, you know, do we think that someone has been investigated enough, and there's sort of a concern about, you know, questionable red flags, then we've got medical opinion kind of on hand, and then they can, you know, order further investigations, do further clinical assessment. And once they're sort of cleared of those things, then we find ourselves in a similar position with a lot of people we see with persistent pain, where essentially their investigations have come back maybe showing something, but something that is sort of not in proportion to the symptoms that somebody's experiencing, or that there's not a sort of clear-cut medical treatment that would be appropriate for them. So then we're kind of taking a similar approach to persistent pain, of kind of educating people around why it might be they find themselves and their body systems sort of reacting in this way, and what are the sort of strategies that they can put in place to support themselves. And that's what I was saying in my presentation that I gave, was sort of, we have so many transferable skills from persistent pain when all investigations and tests are kind of coming back normal, and that can feel quite invalidating for people who are experiencing something that's really, really impacting on their everyday life, and really quite distressing. Yeah,
it's wonderful that you're part of such a team. You know, I guess that you had to put it together. It had to be put together quite quickly to deal with this. Your point about invalidating. So for patients that have maybe symptoms of maybe an exacerbation of pain or new pain that you think is linked to long COVID, how do they react to the explanation? Because I guess pain is often seen to be something to do with injury, and all of a sudden you're bringing in this virus and how it might, you know, how does that play out for you in the clinic? Explaining this to patients.
I think in some ways, because that association for them is so clear, isn't it? It's kind of like, since having the virus, then I've experienced this exacerbation in pain. So when we start to talk about, you know, sensitization within various systems in the body, then it kind of makes a lot of sense for people, and that can actually be quite validating. And then they're kind of like, oh, I get it now, and it's not something else. Like, I think that's people's fear a lot of the time, that, you know, so this has come and then it's caused like a significant sort of damage across, you know, other parts of my body. And, you know, in some situations where people have been like critically ill in intensive care, that, you know, is potentially a real scenario. But what I would say for the majority of people that we've seen is only actually about 2% of people were hospitalized. So majority of people were at home with a sort of mild to moderate infection. Some people were a bit more kind of significantly unwell, but actually we're not seeing so many people who were hospitalized. And so I think it can kind of make sense to people that, okay, investigations have been coming back normal. And then they've got this question mark as to why they're still experiencing what they are. And then when we have the conversation with them, something just really clicks. And then they're just really keen to get going with our rehab approach. And one of the things that we do at the start of people's journey within our service is we do an introductory webinar. So this is something I think is fairly common, definitely across pain services within the UK, where people are invited to the webinar to hear a bit around, you know, our approach and what we do, and then they can opt in or opt out of the service. So if they like what they hear, then they'll opt in. And if they don't, then that's completely fine. And they might be looking for something else, but they're not going to end up wasting their time kind of going through assessments and meeting clinicians and then finding out at sort of, you know, 6 months down the line, this wasn't really what they wanted. And our buy-in is really good. So we have sort of, you know, probably like a 98% opt-in rate. And then it also sets the assessment up really well, because they're coming to the assessment not expecting that we're going to suggest a medication or, you know, a simple kind of quick fix. They sort of have this awareness and expectation that it's probably going to be a bit of a long haul, but how we're set up is to provide them with the support so that they can develop self-management skills and come out much more confident dealing with the symptoms that they have. And hopefully, you know, we are seeing people recover, but it is taking time, and kind of the patience and persistence message for persistent pain also applies with long COVID, it seems.
That was going to be my next question. And then there's a question from the audience. So do we know much about the prognosis of long COVID? So for when they present or when they recover, I guess recovery, it depends on what is the definition of recovery. But can you say anything about that length of recovery? So it's long, but are we talking about?
Yeah, so it's so hard, isn't it? Because we're still sort of just you know, just 2 years down the line, really. So there are some people who are still unwell, having contracted COVID from March 2020. And there are people who are fully recovered. There are some the latest kind of statistics we've got in the our ONS data does suggest that sort of, I think it's around sort of 80% of people are expected to recover within 2 years. So that's kind of something that is quite encouraging. And there's also a breakdown that shows, you know, after 6 months, how many people recover. So it seems that there will be the majority of people recovering over time, but again, it might be more like a sort of months, or for some people going into several years to kind of really see. And also, like you said, kind of what does recovery kind of mean for you?
But it's great with that 98% buy-in, that if people understand that this will be long haul, it might change some of their expectations around, I guess, if they don't recover within a few weeks of attending the service, they're not panicking, you know, they understand. That's great. So there's a question here for doctors working, this is for you, Stephanie, for doctors working with long COVID, would you like to see the regular testing back? Would that help with diagnosis for long COVID syndrome that seems to be less commonly diagnosed and maybe disregarded? That's a great question.
Yeah, really great question. So we were really quite scared with, you know, PCR testing and the lateral flow testing stopping, because we were thinking, oh, well, it's gonna go one of two ways, isn't it? It's either going to be well, people don't know if they had COVID at the time, but it's only 12 weeks later that they're experiencing these symptoms, and maybe they'll get dismissed. Or alternatively, there might be a sort of over-enthusiastic diagnoses of long COVID coming through. So anybody who's had kind of a cough or a cold 12 weeks previously, and then they've gone on to develop a persistent cough, for example, we're just kind of concerned that, you know, are we going to start seeing more people just kind of sent down the long COVID pathway instead of being kind of properly assessed to see, you know, what the cause might be of this new symptom of a persistent cough. And interestingly, it kind of hasn't really turned out either way. We're still seeing some really appropriate referrals coming through. And it seems, you know, that people have had access to some tests and knew that they were positive at a particular time. That landscape might change, I think, in the next 6 months. We'll have to kind of wait and see. And it's all just kind of weighing up, really, isn't it? Of sort of would the kind of the sort of government approach and the sort of population health approach. I think we've just got to adapt. So that's something that as a service we've had to do constantly over the last
very
couple of
quickly
years.
as well. Yeah.
Is very quickly adapt to something that changes really rapidly. And I think, you know, we just kind of fit in with that. And one of the things that really helps us is actually there's a really, really good network of clinicians that come together. So we have an AHP network for long COVID across London, but it actually has a sort of national and an international reach that the NHS England sort of supported in its setup. And also just regular communication with, so in my region, I communicate with all of the service leads across North East London. And then we also have a regular meeting with the NHS England London team. So we're constantly kind of having meetings and asking questions about, you know, what are you seeing now in your service? Or we've had this person through with this symptom. Can anyone help me out? So it's very much a sort of, a network so that we can get kind of consensus opinion where there's research lacking and kind of really clear evidence-based guidance lacking.
Yeah, it's really a developing situation. You'll probably be updating your lecture again soon on the Academy with more information for all of us. It's great that you have this system and all the EFIC audience can learn, I guess, from your experiences. So that's great. So Annaleen, we have a question for you from the audience, and I have lots of questions as well. Can you say something about nutritional deficiencies in relation to pain? Is there some kind of biochemical marker for pain? Interesting question.
Sure. Yes, indeed. Well, there is some research looking at cross-sectional studies looking at the diet of people who are in chronic pain, and indeed there are overall some things that occur over several populations with chronic pain. And when we look at their monomentality diet, it's often high in caloric consumption, so a lot of calories with less nutritional value. These diets are also often high in sugar, high in fat, high in salt, high in caffeine. So therefore, it's an assumption, of course, that those kinds of aspects are linked with the pain intensity. Other things that we see is low consumption of vitamins, specifically vitamin A, B11, B12, vitamin D. Also low consumption of calcium, magnesium, so several minerals. So indeed, we can state that people with chronic pain often have a less healthy diet, and a diet that is not so high in nutritional value. And there is also some interventional research looking at, okay, if we change the diet of these people, does it have an impact on their pain intensity? That research is mainly focused at the moment still to fibromyalgia patients and rheumatoid arthritis patients, so patients with more widespread pain symptoms. And there indeed we see that changing to a more plant-based diet, it doesn't mean it has to be vegetarian or vegan, but the plant-based options have to be the major part of the diet, then it appears that it can have an impact on pain intensity. The pain intensity will decrease. And from animal studies, we even see that if we switch animals back to their high-fat diet or high-caloric diet, the pain intensity increases again. So there are some voices raising that indeed bad quality fats, diets high in sugar do have a link with chronic pain. Another thing which is maybe not specifically related to specific nutrition, but of course it has got something to do with it, is of course obesity and overweight. We do see that a lot of people with chronic pain also are overweight or obese. And there, of course, we can have the link with a higher load on the body. The higher the weight is, the higher the load on the body. So this could be an explanation for an increase in pain due to overweight. But we do see that there is also a link that goes beyond the load, that probably we all know overweight, obesity causes metabolic syndrome, causes a sort of inflammation, and low-grade inflammation, systemic inflammation, which is also seen in people with chronic pain. So probably this inflammatory aspect is probably the one linking nutrition, overweight, and chronic pain to each other.
Yeah, I think the inflammatory theory is interesting because I guess we see this as well with poor sleep, stress, depression.
Sure.
They all have that component. I guess one of the key questions for you is that I have is when you say diet, being overweight and pain are related, do you think it's chicken or egg, or could you comment on, I guess, the causality here, or what comes first?
Well, that's a difficult one because there is some evidence for both ways. For example, people who are in chronic pain, they often tend to make poorer choices in nutrition due to the pain. They have less motivation, less let's say space in their head. I don't know how to say it good in English, but less space in their head to work on a healthy diet. So it's often more easy to make the poorer choice in nutrition. So in that way, chronic pain can lead to poor nutritional choices, can lead to overweight and obesity. But of course, it's also the other way around, that we see that people are first show overweight, and which is then linked to less physical activity and poorer choices in nutrition, and that leads to chronic pain. So it's actually a bidirectional relationship, and it's very individual which one comes first.
Yeah, and we see there's a genetic vulnerability to chronic pain and obesity. Do you think that's a large factor in, I guess, having this shared presentation, that because of maybe a certain genetic profile, people are more likely to have pain, more likely to be prone to obesity, etc.?
Yes, well, I'm not aware of specific evidence on it, but probably given the common underlying mechanism of the low-grade inflammation, the metabolic profile, probably there could be some genetics to explain the link. We're also focusing even on the epigenetic part of nutrition and of chronic pain in general here in our research group. But again, it's all starting research, so I don't have specific results or evidence on it yet. But actually in clinic, when I see chronic pain patients, not related to nutrition or obesity, but just chronic pain, I also explain them the genetic part of chronic pain, and that of course it occurs more in some families than in others. And I always tell them, but that's not something we can take into account, or that's not something we can do something about. So I believe it's good for the patient to know that there is a genetic factor. It gives an explanation, but I always set it a bit aside and I move forward to the things that we can focus on.
Yeah, modifiable factors. I always worry with pain. Well, I guess obesity and being overweight, that's a global problem beyond pain, but I always worry, the same with exercise, that we put a lot of pressure, we place a lot of the responsibility on the patient to make these huge behavior changes, whether it be their diet, how much exercise they do, what they eat. Do you know if there's much evidence happening that's more broader to help people make these better choices? So if we think about, you know, commercial advertising, the availability of high calorie foods, you know, life, it's just easier now to eat more and move less and these things. Can you comment on, I guess, evidence outside the individual that could, I guess, help people with obesity and being overweight?
Yeah, you're completely right, because of course the pandemic of obesity goes beyond people with chronic pain, and you're right that it's nowadays it's easier to be sedentary, not to be physically active, and to make poorer food choices. We also see that's something that has been published. I'm not sure if it was 2020 or 2019. The Eat Lancet Commission. It's a commission formed by Lancet on diet in general, and indeed they also comment on the fact that poor nutrition choices are often the more healthy choices to be made. So the Eat Lancet Commission is of course internationally, but for example here in Belgium, also nationally, there are a lot of campaigns to alert people that also healthy nutrition or healthy food choices can be affordable. So I think there are a lot of tips you can give your patient or the general public on how to make healthy choices that are affordable. For example, of course, it's something that we might have lost due to the fact that everything is always available to us. But of course, certain kinds of fruits or vegetables will be more cheaper if you buy them and eat them at the time they are actually grown. We are used to the fact that if I go to the grocery shop, I can eat a banana or a mango anytime I want. But of course, that's not something that used to be like this in the past. And if you eat according to the seasons, it will be already more affordable. Or for example, another tip I always give to the patients is the fact that frozen fruits and vegetables they don't lose a lot of nutritional value, and they are often also more affordable, easy to use. So I guess there are always a lot of barriers, not only with regard to the financial aspect, but also with regard to the fact that it's sometimes more easy to make a poorer choice. You don't have to cook, or you can just heat something. But if you just guide your patient a bit, you can actually tell them and learn them that it's also possible to make a better or more healthy food choice.
Yeah, and I guess just from your own experience with your own patients, how do they take to these types of messages? I guess the idea of bringing up someone's weight as having a role in their pain, I guess I'm interested in how do they react? And if the reaction is positive, how long does that behavior change take? Because I guess it's like exercise interventions, diet interventions, some of them can work in the short term, but then the problem is trying to get that long-term sustainable behavior change. Yep. I'd be just interested in your own experiences.
Yep. Well, how I do it, of course, you're right that it's not always easy to bring up weight or to bring up things that can be maybe a bit sensitive. So when I have my intake with the patients, I just generally question everything. And I also explain to them at the beginning, I'm really going to do a very broad intake because chronic pain is complex. There are a lot of factors contributing. And at the end, we'll see where which aspects can be related to therapy. So they start talking. And then in the end, I bring everything together. I also show them this kind of diagram, which includes, of course, biopsychosocial factors, but then also lifestyle factors. So they see that it's just a general framework, that it's always included in any kind of intake that I do. And I start to explain how each factor, like for example, also sleep, stress, and weight is one of the factors that is included there. And I start to explain how it relates to chronic pain. And then together we come to a shared decision to see which aspects we're going to work on first, because it's often multidimensional, very complex, and it's impossible to start working on each of those aspects, because of course, if you're sleeping poorly or if you have a lot of stress, it also demands behavioral change. The same for increasing physical activity. So it's a complex treatment as well. And so it's very individualized. If sometimes people are very eager to start working on their weight, for others, it becomes first a bit in the background. And as you're working with the patient, your therapeutic alliance will grow, and your bond, your relationship with the patient will grow, and it will become more easy to start implementing things around weight, or you can see that the barrier will drop down a bit. But of course, it involves a lot of communication, a lot of trust, and the relationship needs to be built. It's not something you can start on from the beginning, from the first conversation. And with regard to the long term, again, I don't have data specifically for the chronic pain population, but of course, from general behavioral change, we do know that in the end, when we come to the end of the therapeutical sessions, we need to prepare the patient for the time after the sessions. We need to talk about the fact that it's normal to have a relapse, how to deal with it. We have to talk about possible barriers that will come along in the upcoming months, how to deal with it again. And we also know that sometimes booster sessions could be useful. A small or a short interaction between therapist and patients, or something online to guide the patients to get back on track if they go off the track a bit.
Yeah, it's very complicated, and it's not only with diet and weight, but when people do have a flare up at home, everything can go off track. And
yes,
I think that's one of the major difficulties, is how do we get people managing this type of stuff on their own, and I guess getting over those times where they relapse or get a flare up. I think that's a big factor.
I guess it's all about giving them as much as possible the tools for self-management, but also allowing the option to come back to you as a therapist if they need some help with getting over some obstacles they are facing.
Yeah, and I think, I'm a physio, but I'd love to work more with, I'd love more cross-sector collaborations between healthcare and the community. So when you discharge them, you're not discharging them into a community that just encourages the behaviors that you've tried to change. And I'd love to see that going forward. There's another question I have for you. So in terms of obesity, we'll say, do you think non-pharmacological interventions are enough? So diet, exercise, anything affecting the energy balance without using drugs? Or do you see a role for surgery and type drug interventions, like bariatric surgery, but also, I know there was a trial, I can't think of the drug, in New England Journal of Medicine, where people received an injection. I can't think of the name, but anyway, do you see a role for those with some patient groups?
Well, before setting up the trials that we're doing now on that topic, I've talked with some doctors, medicine doctors, specialize in overweight and obesity. And I'm not sure if it's the same in other countries, but here in Belgium, as soon as the BMI goes, so the body mass index goes above 40, people are eligible for a surgical intervention.
Okay.
And they advised me, the medical doctors, they advised me not to include people with a BMI over 40, because from studies, it appears, or from their clinical experience, it appears that as soon as people are eligible for a surgical intervention, their motivation for a conservative intervention will be very low. Because again, the surgical intervention seems like the easy way to deal with the overweight, while of course it's not an easy way to deal with it. But so those people often are less motivated, and of course you need the motivation for the behavioral change. So and we see a bit the same for people who are just below 40, because of course as soon as they are above 40, they will be eligible for the surgery. With regard to the pharmacological interventions, I'm always a bit I don't dare to do big conclusions about it. So as I'm not a medical doctor, I like to stay far away from it. So indeed, if I'm looking for my field, physiotherapy, but of course combined with dietary interventions, we do see that it has benefits, even if it's just the conservative intervention without pharmacological interventions. And also that if we do a weight reduction intervention, if you combine diet with physical activity, it will have a better outcome than either one of those aspects alone. And also that the effect of the weight reduction intervention goes beyond the decrease in weight. For example, in people with fibromyalgia, you don't only see a decrease in weight, but also an increase in quality of life, for example, an increase in body satisfaction, even a decrease in depression and anxiety. So it also has an impact on more cognitive psychological factors. And the same for example, there's a review focusing on chronic non-cancer pain, and the same is seen there. Not only weight is reducing, but also pain is reducing, function is increasing. So indeed, it can have some benefits. But yes, again, it's like you said in the beginning, a lot is depending, of course, on the patient, because they are the ones who will have to do it. And as a therapist, your role is more coaching the patient towards the right choices.
Yeah, definitely, it's a very complex area, and the research is building all the time. But I'd love to see more support, particularly for people from maybe a low socioeconomic standing, that need more help. We have a question from Stephanie. You can unmute yourself there.
Hi. So yeah, I was just listening with a lot of interest to your conversation together. And Mary said about you'd love to see people being discharged into more supportive communities and kind of thinking about the sustainability of behavior change. And I suppose like with long COVID right now, we're in this opportunity to be quite innovative and quite creative with how we're working with people, because we've got an uncertainty of funding. People are struggling with kind of the workforce to kind of borrow from other areas to support people with long COVID. So we're thinking a lot about how to make sustainable support, because there might not be the sort of funding to continue with clinical support for services. And so something we've been working with is we've secured a grant that we're going to do some community partnership work. And part of that is also tapping into, we don't hardly see anybody with intellectual disabilities being referred into the service, or there's definitely health inequalities of people being referred. So we've got this opportunity really to start kind of experimenting with, well, what if we did some awareness raising campaigns out into our local community. We've made some contacts with public health, with you know, voluntary sector organisations, with the advocates who are sort of, you know, based within those communities, to firstly raise awareness, and then secondly, if at some point in the future there wasn't a clinical service anymore, but fingers crossed there will always be somewhere to support people, but how can we kind of transfer our learning to make sure that people are supported within the community? So I'm really keen that, you know, if we can kind of pilot this within long COVID, that there could be some real learnings for you know, taking it across into things like persistent pain, but other long-term conditions. And, you know, like one of the courses we're going to run is a cook and eat course specifically for people with long COVID. So there's a lot of food sensitivities. People are coming up, you know, they're coming to us and saying, whenever I eat certain foods, my symptoms significantly increase. So we, you know, we have a plan to work, we've got a dietitian in our service and a plan to work with, you know, the community organisation that runs cooking classes with our dietitian, with the kind of long COVID knowledge, to then, you know, signpost people along to that course, so that we don't need to run the cooking courses because we're probably not the best people to be able to do stuff like that. So yeah, it's quite exciting that we kind of have this opportunity, but also that I hope that it sort of creates a legacy for other conditions like pain to use a similar sort of approach, which I'm sure does happen in many other areas, but it feels a little bit new for us in East London.
Yeah, that is very exciting. And of course, patients spend most of their time in the community. So it makes sense that we try and get more interventions within a person's personal communities and their social connections. So yeah, I'd be looking forward to hearing more about that, Stephanie. So Owen has a question, and I think we're near the end of the webinar then. Yeah, go for it, Owen.
It was just more of a comment and observation. I suppose it was mentioned there about some groups not taking people with disability. And I suppose I've done some work around palliative care and disability, intellectual disability before. And there was two issues. One, non-referral, because they were seeing that they wouldn't be, that service, specialist service wasn't for people with disability. And two, when they were referred, there was a lot of comments and situations where they weren't taken on because we don't take people with disabilities. So there was two aspects to it. But I suppose what it really raises in relation to practice and communities and how we work as healthcare professionals and health and social care professionals is there is a strive for specialization, and specialists can be very important and contribute a lot, but there is a need for generalist specialists as well. Mm-hmm. And you know, then services become accessible to everyone. And this, I fully support specialization, but not everyone can be a specialist, and not everyone needs to be a specialist, and not and just because it's not a specialist services doesn't mean that you can't get good services or refer people in or be in there.
Yep, I totally agree. It would be great to see more awareness of all of these things that we're speaking about today, because I think a common thread runs through in terms of misconceptions, greater awareness, greater general community interventions as well. So I'm going to bring the webinar to a close now. That was fantastic. I'd like to thank Owen, Annalene, Stephanie. That was really good. Thank you for your input, your enthusiasm. Everything was excellent. And I hope everyone listening enjoyed it and learned a lot of stuff. Okay, thanks everyone. Have a good day. Bye.
Thank you.
Everyone.
Bye.
Take care.